morning to all of you. It's really a pleasure to be here. And, you know, I'll try and do this talk justice. But Catherine Matthews has a couple advantages. I mean, first of all, she's a foot taller than me. Second of all, she's got that South African authoritarian accent. So, well, props to Catherine, and you know, our hearts are with her during this time. So this CME talk is on overactive bladder. I do not have any relevant financial disclosures. I'm not on the Speakers Bureau for any of the pharmacological agents that will be discussed. And we're going to be talking about effective treatment plans for women with OAB. Maybe we can start talking about the dialogue and coming up with ways to communicate about this, including asking patients if they have problems with urinary incontinence, which I think is going to be coming up as one of these Medicare markers for screening at some point in time. Obviously, a lot of the medications, there's no super medication out there, but many of them are very effective and, you know, can be very useful in the majority of patients, but we have to learn how to minimize the side effects. And we can talk about some of the other emerging technologies, as some of these medications don't work all the time, and the things that we can do to treat women who have refractory conditions. So, this is a very common disorder, urinary incontinence. This is a funny slide, because the main reason for incontinence for a lot of women, particularly stress incontinence, is pregnancy and having babies. And in men, you know, the prostate, not only a BPH, but also surgery to treat prostates. And let me tell you, I haven't seen a few men. Men are not used to wearing pads. It is devastating. You know, these women, you know, they come in and you've had menstrual pads. But men, for the few that I've treated with this mostly post-prostatectomy issues, it is very, 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 very difficult to talk about and very embarrassing. So most incontinence, though, does affect women. The prevalence is up to 55% of women, 5% of men, again, mostly from prostate or post-prostate surgery. The prevalence and severity does increase with age, and it is present in over 50% of people in nursing homes. And in fact, it is actually one of the most common reasons why families put members into nursing homes, is to deal with bladder and bowel control issues. The other little fact is that more pads are actually sold for urinary incontinence or light bladder leakage than they are for menstrual loss, which is incredible. And now you have this whole Kimberly-Clark thing on the boys' pads, and lots of money in the pad industry. So the stereotype is that it's just older people who have this problem. It doesn't happen to younger women, but the reality is that women in their under 40s, about 10% have incontinence, and you know, after age 40, between 40 to 49, it's 1 out of 9, or 11%. So it kind of is almost as much as you know, breast cancer. This is a very prevalent condition that does cross also socioeconomic and all different ages. And I have to say, the youngest patient that I treated for incontinence was 16. The oldest I've done surgery on was 97, but she was still wearing 3-inch heels. So, you know, I do not discriminate. Obviously, this is a slide from Vachi Manasian. I actually know Vachi really well. He's now at Harvard, but at the time he was at Geisinger, and he's done a lot of good epidemiological research on this. He and I are on the same Public Order Disorders Network, which is this research network at NICHD. And he's done this wonderful research looking at, he really calls it tip of the iceberg type of research, in that the amount of women who actually complain of this, we're only capturing the tip of the iceberg, because it's sort of like the top 20%. But there's this other 80% of people who have the problem, and clearly it's growing. You know, there's expected to be a 56% increase in the services for people with pelvic floor disorders over the next 4 decades, because of the census and as women are aging, I mean, what happens is there's more mild and moderate, say around your 30s and 40s, that becomes along the black bar more severe as you get older. And then again, a reason, for placing people, institutionalizing into nursing homes because they can't deal with it. So I do have patients who come to me and they'll say, Dr. Glazy, I want you to fix this because I don't want to be like my mother and I don't want to end up with a home in a nursing home. Or if there's anything we can do, let's just try and treat this now. So clearly, this is a burgeoning problem. By the time you're 80, it is said that probably 80% by the time they're 80 have urinary incontinence. But even in their 40s, I would say it's like 1 out of 3 women in their 40s has some problem. Now, the mix changes because we'll talk about the different forms. The post-childbirth type of leakage that relates to the garden variety loss of bladder support, which is stress incontinence, is more prevalent in the 40s. But as you get older, the overactive bladder and the more mixed picture becomes much more prevalent. So this is a case that I'll present that Catherine wrote up, but as I read it, I'll say something funny about it. So this is a 48-year-old Mrs. D who's perimenopausal white female. Approximately 1 month ago, she began experiencing urgency, frequency, and urge incontinence. And in the past 6 months, she has gained nearly 25 pounds, which she attributes to perimenopause. So she now has a BMI of 28.5. And so as I was reading that, I was like, well, this is sort of autobiographical. Save for the white part. I would say I was a Pacific Islander. But anyway, but the perimenopause and the little weight gain thing is definitely apropos. So she's noticed, and my husband would definitely agree with this part, a decline in sexual desire and satisfaction. So she feels anxious and nervous and embarrassed in public, and I did go to the bathroom before this, and I had to make him unlock it. Could you imagine? I said, I'm about to give an overactive bladder talk, and you have this bathroom locked. So they emergency open an unstat for me. She takes her hydrochlorothiazide and propranolol for hypertension, and the SSRI for mild depression. So, this is a very common scenario. I mean, I kind of relate to it. The International Incontinence Society defines overactive bladder as, there's a triad of urgency, with or without urge incontinence, frequency, and nocturia, in the absence of some reversible factor, urinary tract infections, prolapse, or something pathologic or metabolic. And the interesting part is that the urgency in and of itself can be very bothersome for patients. You don't necessarily have to be wetting yourself and wearing pads, but the fact that you have to go frequently and get that urge or the call, that's very bothersome to people because they just feel like they can't make it in time. And what ends up happening is that they end up training themselves and going so frequently because they want to get that feeling of urgency to go away, or they're afraid that they want to avoid getting an accident in public. So that bladder training issue, then it becomes a self-fulfilling prophecy because the more you go, the less compliant your bladder is, and the more severe your symptoms get. So stress incontinence, again, this is the leakage with lap, sneeze, jumping rope, running, very, very common, and this is the type of leakage for which women can do surgery for. And we have some of these newer slings that we have, which are outpatient, 86% cure rate, but that's not what we're talking about today. Today we're talking about the urgency, or the gotta go, running to the bathroom in time. There's another type of incontinence called overflow, which can happen in men with prostates. Typically in women, a common scenario is either with diabetic neuropathy or with prolapse and dropped bladders, where there's a blockage, there's some kind of bladder outlet obstruction. So the bladder gets overfilled. MS, Parkinson's, those are other neurogenic causes, but then it can only fill so much and then it overflows. I just had a patient who recently was post-op, and we had done a sling, and she had called, and my fellow had answered. And she said, yes, I'm going to the bathroom so frequently, She was 2 days after we did a robotics, a pulvopexy and a sling, and my fellow got the call at night saying, oh, you must have a urinary tract infection, your catheter's out. And I followed up in the morning and I said, Mrs. So-and-so, how you feeling? And she says, well, I'm going to the bathroom so frequently that I feel like I'm pregnant. And as it turned out, what my fellow wasn't understanding is that she wasn't emptying completely. And, left to her own devices, this could be an emergency, because if your bladder gets too over-distended, it's sort of like elastic that gets overstretched. Once it's overstretched, it doesn't get back to its original shape, and nor does it get back to its original compliance. So those kinds of things, she was a first-year fellow, kind of missed the boat on that one, but fortunately did call early enough that when she came in and we capped her, she said, I just wet myself on the way over here. 1,400 cc's. So be careful with that one, and your diabetics and those who are post-obstructive, either from surgery or from a prolapse. Transit incontinence, most of the time this is related to a urinary tract infection. Certainly we'll talk about some of the psychological issues as well. Functional incontinence, this relates to women who there are some reasons why they just can't make it down. Maybe they have problems with their gait. Maybe they need a bedside commode to be able to make it on time. Maybe they have arthritis and they really can't unzip their fly or undo the buttons fast enough, but you can make some practical considerations of using Velcro or elastic Chico's pants or something making it easier for them to function and make it to the bathroom in time. So let's look at this overall overactive bladder universe, which apparently affects 33 million people, about 16% of the population. Of those, a third are what we call overactive bladder wet. So that means that 37% have overactive bladder urgency, frequency, and the incontinence, and they're likely using pads. And 2/3, though, of the adult population are overactive bladder dry. They just have the urgency, frequency, and they're still bothered by it. And they may not be wearing pads, but it is an issue and probably should be addressed. Now, this was a mnemonic by a geriatrician, which I thought was really quite apropos. The mnemonic is diapers, and it relates to reversible forms of urinary incontinence. That means things that we can do to reverse it. So delirium, obviously there are some delirium like vitamin B12, folate deficiencies. In some small cases that's reversible. Certainly that cognitive effect could be the reason. Infection. So infection, urinary tract infections, that's another reversible form. You treat the UTI or whether it be a vaginitis, and your symptoms can go away of dysuria, the urgency and frequency. Urogenital atrophy. I know you guys have had a lot of hormone talks and you've had some super names at this conference, and I hope you take advantage of listening to those lectures. I wish I had heard Marcia Stefanik. But anyway, atrophy, urogenital atrophy. We have level 1 evidence that now that everyone has stopped hormone therapy systemically, I'm still a really big fan of estrogen in the vagina. And we know that we have level 1 evidence that if you replace estrogen, at least in the vagina, and there are ways that are safe with the vaginal creams, rings, tablets, that replacing estrogen locally, we have level 1 evidence that you can prevent urinary tract infections. And in preventing the urinary tract infections, you can prevent some of these symptoms. So I'm a really big fan of it. I have to tell you, I see a lot of recurrent UTI patients, a lot of them from the urologist and me, even in my own department at Georgetown, who don't want to deal with it, and they don't know how to prescribe the hormones. But that could be a game changer. So I'm a big advocate of using it in the vagina. Other pharmacological treatments, I mean, clearly, I'll go over this a little bit later, but alpha blockers, certainly diuretics, those types of medication can adversely affect bladder function. Psychologic, I mean, we've got some people who've got polydipsia, they're psychogenic. I'll have patients coming in and say, oh, I'm going to the bathroom so frequently. Meanwhile, she's got a 24-ounce bottle of Smart Water the whole time she's talking to me. And I'm like, what goes in, what goes out. It's almost like ego. But obviously, there's psychological influences that we can deal with. Endocrinologic, Certainly diabetes out of control, not so good for the bladder because that can lead to frequency and polydipsia, causing overactive bladder. The other thing that the E stands for is excess fluid. That means drinking too much. And generally speaking, you know, someone should drink to thirst. You don't need to necessarily drink 8-ounce glasses. Drink to thirst. Make sure that your urine, what's coming out, is sort of like lemonade color. But 50 to 70 ounces is pretty normal. The other thing is that the E stands for is edema. So the people with congestive heart failure, you know, or who've got venous insufficiency, and they've got all those veins, and you know, they've got all the edema, the pitting edema, pretibial edema in their legs. Well, what happens when you lie down is that clearly all that excess fluid in the interstitium comes back to your venous system through the vena cava, gets cleared through the renal artery, and you make more urine at night. So I do recommend the Job's Toes, and then there's another brand called Juzo. They're actually come in more different colors than Job's, it's J-U-Z-O. And for women to wear these hose to prevent that capillary leak and the fluid. And that's another thing because maybe that's what's causing them to get up so much at night. Restricted mobility, we talked about that before, you know, for whatever reason, you know, ankles, arthritis, back issues, not making it to the bathroom in time. We do recommend sometimes that people get bedside commodes. I have to say, we have a lot of classy ladies here in Northern Virginia and Georgetown who do not want that, and they certainly don't want their friends knowing that they have that. So, you know, they have diapers and stuff that they wear at night. And then there's different toilet assist, you know, not being able to sit down so that you can raise the height of the toilet seat. A lot of things that you can work with your occupational therapist, physical therapist for to help. And then finally, stool impaction. This relates to the case. A lot of the medications that we'll be discussing are anticholinergics, which cause constipation. But if you have constipation, you know, there's only so much room down in your pelvis. Things are moving slower, you're going to have a harder time emptying. Treating the constipation can help. So, you know, we talk about adequate dietary fiber, since apparently the average American only gets about 10 grams, and all the white bread and the white rice aren't good for us, and we're supposed to be getting at least 25 grams of fiber. So we talk about adequate dietary fiber. I actually do recommend the use of stool stoppers and even Miralax on a regular basis to keep people regular. Because you know, regular is having 3 bowel movements a day up to 3 a week. So if you're not having that many, then there's an issue. So what people say, and a common thing that people say about incontinence, is that it's not going to kill you, but it takes away your life. So the quality of life, talking about the psychological loss of self-esteem, feeling like you're a burden, worried about the odor. I mean, I have patients who say, you know, Dr. Ecclesia, I don't want to go near my grandchildren because I'm afraid that they can smell the urine. You know, I don't go to church anymore because I'm afraid I'm going to have an accident or have near misses. So then they isolate themselves, and there's reduction in social interaction. Sometimes they can't fly anywhere. I've actually had patients who literally asked me, Dr. Ecclesia, could you write me a prescription so that I could get an aisle seat? And during 9/11, there was an issue where people couldn't, you know, the last 30 minutes, that would be a game changer for some people. They wouldn't want to go on that trip because they couldn't make it, and they weren't sure, particularly here in Washington, because they wouldn't let you get up to go to the bathroom. So we were, for a while, writing bathroom permission slips. You know, people are getting specialized underwear and a lot of padding, specialized clothing. I have to say that some of these devices have improved significantly with more moisture controlling. There's a nice organization. I'm a former board member, so I'll disclose that, but the National Association for Continence has a really nice catalog that you can look at as a research, NASC.org, and it'll tell you about some odor reducing and has a comparison about the different pads to recommend to your patients. People will be losing work from this. Yeah, definitely avoiding sexual contact and intimacy. I've had patients say, you know, I have had leakage during sex and during orgasm. I said, well, does your partner know? He goes, no, He doesn't know, he just thinks I'm very excited. I find that probably is very true. All right, so let's talk a little bit about the physiology in terms of storage and nutrition. So obviously, we've got 3 different systems here. You've got the somatic, the sympathetic, and the parasympathetic. So long story short, parasympathetic nervous system, major neurotransmitters, acetylcholine. You'll see a lot of drugs are anticholinergics. Because if you remember the parasympathetic nervous system, they have very long preganglionic neurons and very short postganglionic neurons. The postganglionic neurons are in the bladder wall itself, and it's that anticholinergics, your ditropan, Detrol, Vesicare, Enablex, etc. drugs that are blocking those anticholinergic receptors on the bladder wall itself. The sympathetic nerve, and so the parasympathetic nervous system is mostly involved with bladder emptying. And so that's bladder contraction. The sympathetic nervous system is mostly involved with bladder storage. Norepinephrine is a major transmitter. I'll have to tell you that the beta-3s, there's going to be newer drugs coming up on the market that are going to be related to the beta-3, so in your ability to store better. And then the pudendal nervous system, obviously S2, 3, and 4 keep the pelvis off the floor. The pelvic nervous system is involved, the somatic nervous system is involved in the sphincters. So you've got a urethral-rhabdoid sphincter, and you've got an anal sphincter. If you get damage to this nerve, that's when you can have problems with urinary and fecal incontinence, and you may have problems with that kind of dual incontinence, even though you don't have any prolapse related to nerve damage to the pudendal nerve. So let's go here. So again, this is an interarray. So between the central nervous system and your pons nutrition center, through the spinal cord, to the nerves in the pelvic floor. So as the bladder feels storage, you go up to the pons, the sympathetic and somatics take over, saying the bladder, store and fill. And when it's time and you have enough urine that's built up, the parasympathetics get involved, the sympathetics get downregulated, and the parasympathetics take over. And so what can happen if there's any type of blockage, obviously something like a stroke in the central nervous system or MS in your spinal cord, you can get issues with that. So anything that, like let's say MS, so there's a something that, then the sympathetic nervous system is in the thoracolumbar spinal cord, you get some kind of blockage there. The problem with MS is that the parasympathetics still work through the sympathetic, but through the sphincters, they're still going to hold, and the muscle will contract, but the coordination is off. What happens is the bladder muscle contracts, and the somatic and sympathetics, which normally should relax, don't work anymore. So you get a bad problem in that you leak and the bladder squeezes, but then when you want to go, you can't because the sympathetics and somatics don't relax. So this is a very delicate system. I think, neurourology is very fascinating to me, and I think we're going to see a lot more, a lot of different agents coming up, working on different receptors, and I think we're going to see a lot more in terms of neuromodulation for sensory afferents to get to the problem of these nerves that are really at the root cause of overactive bladder. So now onto a practical nature, now that we've gone over some of the epidemiology and we've gone over the anatomy, physiology, pathophysiology, this is what you see, what you do when you see a patient. You're going to take a good history. Obviously, for me, I'm sort of self-fulfilling that you want to ask about urinary incontinence, because a lot of people, they won't say anything to you. You're about to walk out the door and your well woman check. Oh, by the way, doctor, I'm either having a problem with urinary, sexual, or anorectal function. And it's always like, oh, by the by type of a thing. And what you don't want to do is say, oh, well, Mary, what do you expect? You're getting older. That's the worst thing. The best thing to say is, that is a very common problem. 80% of the time we can do something to fix it. If you can make another appointment with me or our associates, let's sort of talk about this some more. But I do understand the problem with E and M coding and can't be not being able to be sick and well on the same visit. So there's certain screening questions for urinary, sexual, anorectal symptoms that you can ask about. You know, obviously, do you have a problem with bladder control? Does it happen more with laugh, cough, sneeze, and stress, or do you have a problem making it to the bathroom in time? Those are very good screening questions. In terms of evaluations, a urinalysis is helpful. Obviously, if you've got nitrites and leukocytes, there's an 80% chance that you have a urinary tract infection. You know, most bacteria will end up splitting that. You'll end up having positive enzymes on your dip. But there are some urinary, so if someone has a symptom, the most common are gram-positive, like enterococcus. That will be a false negative on your dipstick. Physical exam, you know, you don't necessarily have to check a residual at every patient, but if you're examining patients and you feel bladder fullness, that could be a clue. Obviously, if there's a pelvic mass. I have to say, a lot of urologists, not that I'm bashing my predominantly male colleagues, but a lot of them don't examine women. They don't do speccing exams and they don't do pelvic exams. And so they just kind of say, oh, you've got overactive bladder, they get referred, and they give drug after drug after drug. Well, I have found, you know, women who've got large fibroid uterus, and in fact, I have also discovered ovarian masses, you know, stage 3 ovarian cancers. So it is important that we do a pelvic exam. And I don't know, in this day, when we're changing all the screening, you know, now we're going to every 3 years and possibly every 5-year pap smears. I am concerned that people aren't going to come in for their annual exams, and I still think that there is a role for this. You know, certainly for prolapse, certainly for any type of lesions on the vulva, and certainly for masses. It's not the best in overweight women, but it's what we've got so far. So urinalysis and a simple pelvic exam is recommended for screening. And then on this, we're going to continue with the case, which is somewhat autobiographical. But based on her assessment, we learned that she suffers from constipation and has tried to increase her water intake to address that issue. So that is a problem. You're going to the bathroom so frequently because you're going to and you're having number 2 so infrequently. She's also getting up 4 times at night. And you wonder, is this nocturia or is this nocturnal polyuria? So nocturia is because you're getting up because you actually do have to go to the bathroom, or nocturnal polyuria, you happen to be up. And this is where bladder diaries can be very useful. So now unfortunately, only about 25% of the patients to whom we give these actually fill them out, and you get a better turn-in rate if you give them a 3-day diary versus a 7-day diary, and they're apparently both 3 and 7 days are equivalent. But what you want to see on a diary, if you want to really do it right, is that they have to measure and record not only the volume of what they're drinking at the times that they're drinking it, but also how much you urinate. So it will give you a sense as to what's going in and what's going out, and talk about, and you'll get a sense of diuresis. You'll also get a sense of looking at what types of fluids. You know, if it turns out that all we're doing is drinking Starbucks and Diet Coke, which seems to be like, you know, then there's an opportunity for some intervention behaviorally. And if it turns out that they have a very small functional capacity, then they have some problem with sensory urgency. We'd like to see at least 10 ounces, but you're getting that's 300 cc's. Obviously 500 is really good, but you get a little bit more concerned when you're seeing these 2 ounce, 3 ounce, 4 ounce little kinds of dribbles about that you can have some sensory urgency in there, where they really are not waiting long enough. And then if they're drinking everything at 7 o'clock at night, and you know, of their 50 ounces that they drink, 40 of them are at night with dinner and the wine, then there's an opportunity for intervention there, because obviously all that's going to start to flow at night, and that could be a problem. So these diaries are really effective, and I can tell you that the diaries are the reason why there's such a high success rate on the placebo arm of most of these overactive bladder drugs. Because on those trials, even on the placebo arm, the women have to fill out diaries. And so filling out the diaries, I think, give you a sense. So these placebo effects, when looking at these drugs, the placebo effect is anywhere from 30 to 55% improvement. And that's for the sugar pill. But it's because you have these other interventions behaviorally. So, my friend Mary Pat Fitzgerald, who was at Loyola, now she's at the VA, did a really neat study and said that some of the reasons why women are getting up at night may be related to sleep apnea, go figure, and that these CPAPs machines, because sleep apnea apparently is a rampant epidemic in the United States right now, are really actually effective in also decreasing nocturnal frequency. And whether it has to do with, I don't know, angiotensin, aldosterone, there's something, it happens to work. So obviously they go hand in hand, so getting up at night, ruling out another sleep disorder is really effective. Now I think this is one of the questions on your little purple sheet. That happened to look at it on drugs and interactions. Obviously alpha blockers. Why? Alpha blockers, they're used for hypertension in men, they're used for BPH. Your alpha receptors are on the urethral sphincter, so if you block that, the sphincter is wide open, you're going to have more leakage, and actually more leakage for stress incontinence. And in fact, some women who have retention that's unknown, we give them Flomax sometimes for that. Tricyclic antidepressants have an anticholinergic side effect, as do some of the psychotropics and the cholinesterase, so they can actually cause a little bit more overflow, and they can also cause more constipation, as can narcotics. Calcium channel blockers can be, the interesting thing with calcium channel blockers, there's two mechanisms. Not in addition to some frequency issues on the bladder itself, there's this coughing associated with some calcium channel blockers, and that coughing can cause some stress incontinence. Diuretics, obviously diuretics are going to increase urgency. That's the reason why you get them. And we have a problem with that, because you got the people with congestive heart failure, and then you've got the edema. They want to get the fluid off. At the same time, they're wetting themselves. So it's a fine line in giving the lowest dose diuretic that's needed to control the heart failure and the edema, and balancing that with the amount you're drinking and your cholinergic medications. So this is a list of some of those medications. So what you can do, and sometimes I'll just call the primary care physician and say, is there anything else we can give her, besides HCTZ or Lasix for the blood pressure, because she really has a bladder control problem. And sometimes, the doctors really appreciate that call, and they'll take a little special care managing the hypertension. We already talked about decreasing caffeine for the urgency issues, and decreasing overall fluid consumption to about 50 to 70 ounces a day, managing constipation and losing weight. So the skinny, no pun intended, on the weight loss is that, if you lose 10% of weight, you can decrease stress incontinence and the amount leakage by 50%. And that's on the PRIDE study by my friend Lizzie Suback at UCSF. She's done a lot with it. Now, with regards to Kegels, some people think it doesn't work. Oh, Dr. Glaze, I did that, I tried that. And it's because they tried it for about a week, they didn't see a difference, so they gave up. This is something like any other muscle of your body. The pelvic floor muscles are under voluntary control, and if you don't use it, you'll lose it. So, some women do need to get biofeedback, and that's where you place a little probe in the vagina or the anus, and you can make sure you're using the right muscles. Because I would say about 50% of the patients that I see, they say I'm doing Kegels, and they're doing them incorrectly. The cutest one is this little, 70-something-year-old patient. She had a little kyphosis, and she's like, oh yeah, Dr. Glazy, I'm doing those Kegel exercises. It's when you start and stop, like this. So she would take a few steps, and stop. Clearly doing it wrong. But the thing that I really appreciate is that the people who are doing the exercises, instead of squeezing, they're actually pushing down. And that is actually worse. They're using their stomach muscles and they're using their thigh muscles. Another really cute one is like, I had my finger in the vagina. I'm like, okay, now squeeze my finger. And then she reached up and grabbed my other hand. I'm sorry, but you know what? It's really early in the morning. And I just figured, y'all need a few laughs. So, this is a phenomenon. This woman probably has amazing hormones. more muscles and probably has great Kegel, probably Kegels really well. But it is really important for us to understand that. But the problem, and Carrie Bow, who's out there in the Netherlands, who's a physical therapist, a doctor of physical therapy, has published the most on this, is that less than 1/4 women continue. It's like any other exercise. And really, the issue is if you don't do it, and after the therapy, it doesn't last. You know, the benefit of initial therapy was not maintained at 15 years later. So it is something that's lifelong, it's a commitment, you have to do it. A lot of us are a little bit lazier to do it. We've got great instructions, not only at the MEFC website, but the AUGS, American Urogyne Society, or AUGS.org. They have a patient portal website, and it's called, oh my goodness, it will just go to all, I can't remember, they have a separate guideline for that. But on the patient portal side of the AUGS.org, they have lots of instruction sheets on how to do Kegels correctly. I mean, this is a way that Catherine says it. I do mine a little differently. You know, I do 3 sets of 20. You know, you do 10 fast, 10, trying to hold each for 5 to 10 seconds, 3 times a day. I mean, that's just for maintenance. You know, you can over-exercise these muscles, so you don't want to be doing them all the time, because then that can lead to some pelvic pain issues. These vaginal cones, you know, you can see them in a lot of catalogs. You know, you have to have a certain baseline strength, because the lowest cone is like 10 grams, and the highest cone, I think, is like 50. And I've had women who can't even hold the lightest one, it just falls right out. And that can be very discouraging for some people. So those 5 master Kegel exercises, that doesn't work. That's using the wrong muscles. For some women, now this is more for stress incontinence, we have inserts. You know, I call them Spanx for the vagina. Apparently the woman who makes Spanx is a billionaire right now. I can see why. But basically this is an insert in the vagina, like, which has, looks like a little baby teething ring. And if you put that nubbin, the knob, right behind the pubic symphysis, it causes a speed bump along the urethra. So this is really good for stress incontinence. And I know we had the DC marathon yesterday, but I have several marathoners who, you know, have issues after their children are born, and they're triathletes and they can't come in for their surgeries and whatnot, or they're not finished having children. These are very useful, but that's more for the stress incontinence. We've already talked about the bladder irritants, so it's not just caffeine. Some people think the artificial sweeteners, the Splendas, NutraSweets, that can contribute, and certainly nicotine. Not only is nicotine a carcinogen, and specifically the major cause of bladder cancer, but it's also an irritant. And another reason why you might want to stop smoking is because smoking leads to COPD, leads to chronic cough, which is also not good for stress incontinence in the pelvic floor. So, you know, modifying how much fluid, how much is too much, how much is not enough. You know, I say your assay is what your urine looks like. You want it to be light yellow, and obviously you want to drink thirst. Some of these medications cause dry mouth, and so they have to drink more for the dry mouth, but we would recommend sugar-free gum or sugar-free candy in lieu of that. For the xerostomia. For bowel regularity, we talked about constipation, fiber. Obviously, exercise helps keep things moving along the bowel, and getting some kind of regular defecation plan, like reading the paper and your morning coffee, which a lot of people, that's a trigger. And then we already talked about your first-line goal for obese patients is going to be weight loss. You know, just that first 10% can lead to a 50% reduction in the amount of bladder leakage, and the goal to be in a normal, or at least an overweight, not obese trend. So Mrs. D now has eliminated caffeine. She's reduced her hypertensive medication. She's trying to do exercises, but she's still experiencing leakage, and she's still having some nighttime urgency. So at this point, you know, that you did an exam, you ruled out infections, you ruled out obstructions, you ruled out masses, you've done the behavioral stuff, you've referred her on and checked to make sure she was doing the Kegels correctly. Now you can consider a drug. And now, have I got the pill for you? So a lot of the newer drugs are going to be touting their M3 selectivity. So that's the selectivity for the cholinergic receptors in the bladder wall itself, because, you know, we've got muscarinic receptors throughout our body, including the brain, and that can lead to some of this mental confusion. And I have some patients who, Dr. Glazer, ever since you prescribed the Detrol, my mother has not been the same. And that's probably true because of the CNS side effects and this crossing the blood-brain barrier. But the ciliary muscle of the iris, my mnemonic is narrow angle glaucoma, no anticholinergics, but open angle glaucoma is okay. So narrow no, so I say don't have my nurse or have the patient check with her doctor to check what type of glaucoma, because most glaucoma is actually open angle. But you've got muscarinic receptors to salivary glands, and the side effect of dry mouth is very bothersome. That's why the chewing gum or sugar-free candy. It can affect, these drugs can affect your QT interval and lead to rapid heart rates. Clearly, if someone has a QT interval issue, you might want to clear that with the doctor as well. These medications, the muscarinic receptors are found in the bowel. So if you're slowing down and blocking the receptors in the bladder, it slows and it can slow down the bowel as well. And that's where exercise and some Miralax and fiber helps. And then clearly something specific to the bladder, which is more M2, M3 selective. Two drugs that are sulfenacin, trade name is Vesicare, darafenacin, trade name Enablex. And so there have been some trials, and I have to say, there is no drug that's like my go-to drug. And a practical nature, because these drugs are very expensive, they can be on the order of $90 a month. We have an electronic medical record, and we're keyed in with all the pharmacies and their insurances, so it will tell me right away if I prescribe something that's not on someone's formulary. If not, the patients will tell you if they're not on their formulary. So I go first with what's cheapest, since I'm not really a spokesperson for anything in particular. A lot of these drugs, so this was a study of sulfenacin, which is Vesicare. It was a non-inferior study to tolterodine, and it was found to be non-inferior to tolterodine. And they all significantly improved, like on the order of -2, that would be 2 fewer micturitions in a 24-hour period, which could be significant on someone's day-to-day life. And here's what I'm interested in is looking at the reduction in incontinence episodes. The higher your dose, and that's what I also do. I'll start with the medication. I like medications that have titration effects, like Vesicare. You can start at 5 milligrams, move up to 10. Enablex, which is darafenacin, you can start at 7.5, move up to 15. Ditropen XL, which is now generic, you can start at 5 and move up to 30. Detrol, you can start at 2 and move up to 4. I like that to be able to dose it, and I'll say, let's try the lower dose for 1 to 2 weeks, and then increase if you don't see an effect, you're not having too many side effects. And I'll see you back in a month and see how things are going. But do all this behavioral stuff, because look at this, a 55.9% reduction on the placebo arm on this particular trial. And so this is a common theme, because it does tell you that the interventions behaviorally work. The other thing that some of these drugs and people are focusing on more is the urgency and the warning time. So if it increases your warning time, which on average for the darafenacin, based on the 2 different doses, was 4.3 minutes, that could be the difference between wetting your pants and not, being able to make it to the toilet or not. So that might be significant for some people. Now, trospium is the only one, all the other drugs that were on that long list were tertiary amines. Trospium is a quaternary amine, so it's a larger molecule, but it's a little bit more cumbersome to take. The good news is it's trospium. There's 20 milligrams twice a day. There's also a 60 milligram just once a day drug. You have to not take it with food because it's lipophilic. So you want to take it so that you have to take like first thing in the morning and then eat an hour later or 2 hours after your meal. So I would say take it first thing in the morning. You can take with your Fosamax or whatever it is that you're taking, and then do your exercise, and then move on with your day. So that's the only thing about it. However, it is the one that I use for people with some dementia, and I do use it for people who are on those Alzheimer-like drugs that are cholinergic in nature. So we know that a lot of people aren't finishing up with these medications once started, and the reasons are, this is a really important slide, it's because they didn't pick it up, they didn't think they needed it, it costs too much, and 17%. Here, the side effects, mostly dry mouth and constipation, or you forget to refill. And it turns out it's the majority of patients who are not refilling the drugs once started for those reasons. So I think it's good to get buy-in. It's certainly good to understand the cost, particularly in fixed income people. So fitting it into your schedule, availability of generics, understanding the mechanism and when you can do this and reducing side effects. Now I have some patients who I only take the drug when I'm going to the Kennedy Center because I want to be able to sit through this opera or the movie, or I'm going to take it on the flight. And so that's okay. I don't think it works as well, but some people will prime themselves up for a week before something like that happens. And I understand the economics, and if that's what's working for them, it may not be ideal. It's better to take it every day, but I do understand that. So we already talked about this. The only thing I didn't talk about was reflux. Obviously, if there are muscarinic receptors in the gut, so if you're slowing things down and someone has reflux, it may not be the best option for them. And then there may be some people who putting them on the anticholinergic throws them over the edge and puts them into urinary retention. If you started this and people say that I don't feel like I'm emptying completely, or you notice once you started that they're having more urinary tract infections, it might be those people, it might be good to check a residual. So your residuals ideally should be less than 50. But we accept less than 100, and the golden rule is less than 25% of the whole bladder volume. So if someone had 600 cc's in their bladder, avoided 450, you checked a residual of 150, that's actually okay. So you've got to look at that number in context, to the whole. But clearly you might want to lower the dose or switch to a different medication. Crossing the blood-brain barrier, obviously the larger the molecule, the better. Polarity and stuff changes that. There have been some memory studies, and when you look at darafenacin, which is much more selective than oxybutynin, which is much less, the people who are on the placebo and the darafenacin on these memory tests, which were just done at 3 weeks, and I heard Gary Kay speak about this, which was compelling. Those on oxybutynin were almost like as if they were drunk. They couldn't remember the name and the face, and there was no difference in the darafenacin. So that may be a reason for some of these drugs that are more specific, like Enablex and darafenacin, as opposed to the cheaper ones like oxybutynin, which cross. And a reason why maybe you can appeal to someone's insurance company, saying, she had some issues with this drug, and I think that this one should be covered because we really did have some issues if it's working for them. I'm almost finishing up here because I want to make sure I have time for questions, but there's some other things that we do. Now, Botox, formerly known as onabotulinum toxin, that is what we use in the bladder itself. So we do these injections, and usually we do like 30 shots. The average number is 200 units. Each 100 unit of Botox costs $400, and the market is $500. So that's like $1,400. On an average, people need that once a year. So it's a very expensive therapy on the bad side. But on the pro side, this Botox injections have just been cleared. It was just a few months ago, I think in October, when the FDA said that for people with neurogenic bladder, so our spinal cord injury patients, MS, Parkinson's, stroke patients, it actually, insurance will cover it, and it's very effective. The only problem is that in 20% of patients, if you put too much in, they may not be able to urinate, and they may have to self-cap. Now, the spinal cord and MS, a lot of them already know how to do that, and so they're loving it because the other side effects are not working for them. Interstim. Interstim is a pacemaker for the bladder. This is some of the newer neuromodulation techniques that are basically getting to the root of the matter. Most people insert Interstim in the